So I'd like to welcome you all to the latest installment of our year-long discussion series on advancing health and social justice. My name is Stephen Swartzer, and I'm the Associate Director for Academic Programs in Fordham University Center for Ethics Education. So the Center for Ethics Education, which is directed by Dr. Celia Fisher, was established in 1999 as an interdisciplinary cross-campus unit at Fordham. The Ethics Center embodies Fordham's commitment to intellectual excellence, social justice, and human dignity through the promotion of ethics education, research, and public dialogue. Our programs include an interdisciplinary master's degree program in ethics and society, an advanced graduate certificate program in healthcare ethics, the HIV and Drug Abuse Prevention Research Ethics Training Institute that has provided a significant amount of support for our talk series, and an undergraduate bioethics minor. In addition to these programs, we're also excited to have public-facing ethics and social justice programming that engages people in conversation about ethical issues of contemporary social import. So that brings us to today's conversation about ethics and global health research. Now, before I introduce our participants, I want to say a little bit about the procedure for this session. So the first part, we will have the panelists tell us a little bit about their work and how it connects up to this topic, and then we'll have a conversation between them. And we do hope that all of you will be part of the conversation, and we're really happy to include questions and contributions from the audience. So for the discussion, we've decided to use the private chat feature for audience questions. To submit your question, please submit it as a private chat to myself, and then I can read it to the panelists. And you can send me questions at any point during the conversation. And so we really do hope that you will contribute questions to the conversation as it goes on. And now, with no further ado, I will introduce our panelists. First, we have Dr. Purnima Madhivanan, an associate professor in health promotion sciences at the Mel and Enid College of Public Health at University of Arizona. A physician by training from Government Medical College in Mysore, she has a MPH and a PhD in epidemiology from the University of California, Berkeley, USA. She is the director of Public Health Research Institute of India, and also the director of the Global Health Equity Scholars Training Program in collaboration with Stanford, Yale, and the University of California, Berkeley. For the past 20 years, her work, both as a physician and a researcher, has focused on disadvantaged populations, elucidating the dynamics of poverty, gender, and the environmental determinants of health, in particular, the impact on women and children living in rural communities. Then we will have Dr. Rebecca Fielding Miller, who is an assistant professor at the University of California, San Diego, in the Division of Infectious Disease and Global Public Health and the Center on Gender Equity and Health. Her research examines the structural drivers of HIV and gender-based violence in the United States and Sub-Saharan Africa, with a focus on the intersection of race, gender, and economic inequality. She holds an MSPH in International Health, Social and Behavioral Interventions from the Johns Hopkins Bloomberg School of Public Health, and a PhD in Behavioral Sciences and Health Education from Emory University. She served as a Peace Corps volunteer in South Africa from 2006 to 2008, and as a Fulbright scholar in Swaziland in 2013 to 2014. Okay, great. So Purnima, could you please kick us off?
Thank you, Stephen. Good afternoon, everybody. As Stephen said, my training has essentially been as a physician in India. And what I'm going to be talking to you today in terms of ethics and global health is going to start from the time when I had actually graduated from my medical school, being completely clueless what I wanted to do after I finished my medical training. So I went and I worked in an NGO, which was essentially this, not to date myself, was before antiretrovirals were available in India. So I was running a clinic for people who were being thrown out of healthcare facilities in India because they were diagnosed with HIV. So what did I find? Well, most of the women were in their late teens, early 20s, showing up because they had just gotten married, just gotten pregnant, and now they were diagnosed as HIV infected, and nobody wants to care for them. Or they were accompanying their spouses because the spouse had become symptomatic and needed care. So they would come to take care of them. And then we would see that here they are, here's our opportunity to see if we could get them tested and get them into care. So we would do testing for that. So essentially, I started the first women and children's HIV clinic in India, where we started to see women and HIV infected people come from all over the country. But the patterns I found for women were either they were pregnant and they were getting diagnosed, and almost all of them who were dying of cervical cancer. And that was basically what got me thinking prevention. But in medical school, we are not given that much attention and training on prevention, which is why I came to the US to get a little bit more training, and I got my master's in public health, and then I went on to do my PhD. So what I wanted to talk to you today was about this issue around cancer prevention, primary and secondary prevention of cervical cancer, and where does ethics come into it? Well, I just wanted to kind of take you back in time. There were 3 clinical trials that took place in India between 1998 to 2015 in the urban and rural areas of Mumbai and in 2 other communities in Maharashtra, which is one is in Osamabad and then one in Tamil Nadu called Dindigul. What these 3 clinical trials did was they aimed to determine whether trained healthcare workers could actually conduct cervical cancer screening in a community-based setting using inexpensive methods of testing, such as visual inspection with acetic acid, to reduce the incidence and mortality associated with cervical cancer. These trials included 374,000 women, of which 141,000 women were in the control arm. So if you're already seeing what I'm saying, we had 141,000 women in a control arm where they were offered no screening. Although the standard of care for testing for the disease in India has always been cytology screening, or what we call pap smears, and since the 70s, screening for cervical cancer was not universally available, but it is available in India. And for the purposes of the study, the researchers said the standard of care, therefore, was no screening. Known and effective methods of screening for cervical cancer were now withheld for 141,000 women in areas where it is known to have very high incidence and prevalence. Just an FYI, the highest, in terms of the cancers, the second highest cancer in women is cervical cancer in India. There are about 72,000 women who die each year of cervical cancer. So they place them at a known risk of developing invasive cervical cancer and dying from it because it was not detected and treated in time. There were 254 women in the no screening arm who actually died of cervical cancer based on the reports that the researchers had published in these 3 trials. Now, who funded these trials? NIH. And the 2 other trials were funded by Bill and Melinda Gates Foundation in collaboration with the International Agency for Research on Cancer, which is located in France, but it is a specialized cancer research agency for the WHO. So my question is, no screening control arm, would that even have been allowed in the United States? But it was acceptable to the US funders for a clinical trial in India. Now, it's imperative that the ethical standards for research, when we talk about doing this kind of cross-collaboration international research, be equally applied across all nations to prevent this issue that we talk about called ethics dumping, and protect the rights of the participants in research, no matter where they are located on the globe. So The international bioethics debate has basically chastised researchers from high-income countries for practicing double standards and taking advantage of vulnerable people in vulnerable nations, and thus exploiting them for their own scientific goals and profit motives. Inequities among researchers and in ethics standards have since become major issues of concern in these kind of international collaborative research. So ethics dumping, when we talk about ethics dumping, it almost follows the same pattern as dumping in trade, where because of the opening of the global economy, but it's a little different in the sense that ethics dumping takes place because doing such research is either not possible at all in high income countries concerned, or it entails high costs due to the value attached to ethics standards it's required to follow. So now this is matched in the low and middle income countries by either a lack of adequate ethical standards in its guidelines or a failure to convert such guidelines into law and mandatory requirements and therefore enforce them. So when we talk about standard of care, what do we mean? Essentially, it's a concept that has been borrowed from the medical legal context, where we're saying what is reasonably prudent physician would do in same or similar circumstances. Now, this whole debate about placebo and using standard of care as the placebo arm, this debate was basically an ethical debate over standard of care, testing of an intervention against an inactive substance that looks and tastes like a drug, but has no effect on the disease under study. This argument has been going on for decades now. But when we talk about the ethics of placebo-controlled trials, the ethical analysis and the international ethical guidance permit the use of placebo only in 4 cases. 1, there is no proven effective treatment for the condition under study. 2, when withholding treatment poses only a negligible risk to participants. 3, there are compelling methodological reasons for using a placebo, and withholding treatment does not pose a risk of serious harm to the participants. And lastly, the 4th one is when there is a compelling methodological reason for using placebo and the research is intended to develop interventions that can be implemented in a population from where the trial participants were drawn, and the trial does not require participants to forego treatment which they would otherwise receive. So this assumption of that standard of care, no screening is the standard of care for poor women, and so it is appropriate for use as a control condition, is mind-boggling to me. And 76,178 women were recruited in this NIH-funded study in India to serve as unscreened controls in a trial that followed 75,000 women for over 18 years to look at deaths associated with cervical cancer. Mortality was the primary endpoint in this trial. So my question is, when we have PAP screening available in India for women who can afford the out-of-pocket cost, is it ethical to define standard of care based on access to care? Could a trial like this have been carried out in the United States? What could have been the alternate trial designs that we could have used? And finally, was it ethical to use mortality as an outcome? Could there have been some other outcome endpoints we could have used? So these are all the things that I am actually mulling over, because we have been doing cervical cancer screening programs in India, and we used some of these clinical trial data to say that this simple visual inspection with acetic acid works, because that's what the trial said. But when we started using it, we saw so many problems with it that now we have stopped. But I'm just reflecting, when I was asked to give this talk, I was reflecting, how does research inform practice, and how does practice inform what kind of research we do in settings such as this? I'm going to stop there and I'll be happy to take questions, but something to think about. When we are from the global north, what we are proposing in some of these communities, can we do that here, right here? That is the question we should be asking before we go on to do something in a global health setting. Thank you.
Great, thank you so much. So now we will have Rebecca Fielding Miller, and I just remind everybody to please submit questions via the chat function.
Thank you so much, Purnima. I think what I'm going to talk about really plays off that nicely, and so I'm really excited. So a little bit of background on me, like Stephen said, my research up until last June. Now I do COVID, but before that, a lot of my work was in HIV and gender-based violence in the US and sub-Saharan Africa. And I have a long standing relationship with colleagues, in particular in what is now known as Eswatini, what's formerly known as Swaziland. And I have a very distinct memory of working on my dissertation, working on a paper that involved reading a lot of transcripts we had done a study looking at talking to female sex workers who were living with HIV in Eswatini. And it was a qualitative study. I was a study coordinator, as one often is, kind of in their first job out of an MPH program. And so it was my job to train our study staff in qualitative methods, to schedule interviews, to kind of make sure things went smoothly on the ground. And so I met every participant. I actually conducted a couple of the interviews in our study myself. And I have a very strong memory of sitting back in my office in Atlanta, reading these transcripts over and over and over and over again, and not being able to figure out why I just felt so crabby all the time. And these were transcripts where people were asking things like, well, so what was it like when your, alcoholic stepfather abused you and then kicked you out at 15, so you had to begin engaging in survival sex work, right? And you read these over and over again. And I had a bit of a, I got a little shouty at somebody that I shouldn't have, and I realized, oh, this is affecting me. This is a problem. And that experience has really stuck with me. And so I've had a lot of conversations with folks that I worked with in Eswatini, thinking about how does this research not just affect the human subjects, the participants that we're working with, but what does this do to us and our staff as well? And so that's what I wanted to think about a little bit today with you all. So this is sort of our standard framework for ethics, the basics, and I know that you guys go into it a lot more than this, but a lot of what we do is kind of based off this idea of respect, beneficence, and justice, right? This is the Belmont Report. These are the basics. And what this kind of translates to most of the time is, you engage in fully informed consent for your participants. It is your job as a researcher to prevent harm and maximize benefits to your research subjects and the community where you're working to the best of your ability. And it's your job to value people's time in a way, which is to say that research that is not useful is perhaps not entirely ethical. If you're going to be going out and asking people intense questions about their past and previous traumas, it has to be worthwhile or it's not ethical. It's just voyeurism. But I think there's another way to think about research ethics, and I'm so glad to be able to have this conversation about what social justice and research ethics looks like. And for me, as my thinking has evolved over the years, I have thought a lot about how social justice and social power intersect. And I've thought a lot about this from this sort of framework of intersectionalism, which I know everybody here knows, but just as a refresher, intersectionalism is this idea that our different identities along different axes affect how much power we have and what access and what resources we have in a given situation. So you are not just a woman who is experiencing living in a world of patriarchy. Perhaps you are a disabled woman who is simultaneously experiencing misogyny and ableism, and that looks different than a woman who is not disabled. You are not just an elder, you are an elder and you don't speak English, and that looks different than just not speaking English or just being an elder. And so when I think about these relationships, these power dynamics in the research that we do, I think we do a pretty good job we're taught to think through what that looks like between sort of the researcher as sort of the lone researcher on the one hand and the research participants on the other. But I think it's also really important to think about all of the other people who are involved in making a research project happen, especially in global health. So in global health, our research staff often comes from the community where we're working for a lot of reasons. They speak the language, they have more access, they are culturally competent in a way that we're not. They are less expensive to hire in many ways. And I think it's really important that we consider not just the power dynamics between the researcher and the human subjects, but the power dynamics within and across the research study team itself. In particular, with these studies funded in the global north that are executed by PIs that are based in the US or Europe, where the study staff is primarily significantly less well paid and based in the global south. And so what I really wanted to do in this project, which was funded by a Ready Fellowship, so thanks Celia, was I really wanted to think through this experience that I had as a doctoral student, really taking in and processing a lot of these studies that we do on HIV and violence and substance use, in which we basically take these narratives of trauma and transform them into evidence, right? In some ways, that's a lot of what we do. We transform trauma into data. And I think that's an important goal and a worthwhile one, but I think it's also important that we name that that's what we're doing. And we are human beings, right? At our core, we are not objective scientists. Science is not done by a robot or, something that descends from a sky. It's done by a person. And constantly encountering other people's trauma, it affects us. It pains us to read other people's pain. That's a normal and healthy experience to have. And so there's a lot of names for this experience. It's been called emotional distress, secondary trauma, vicarious trauma. There was this really great quote from a researcher doing a lot of work in the VA who said, the great controversy about what he called helping induce trauma is not can it happen, but what do we call it? And I think a lot of us who have done this work, if you think back, you can maybe think about an experience or a story or an informant or even a statistic that just really sticks with you. And so it was important to me to think about, okay, I know I have had these experiences, but if I've had these experiences in a pretty well buffered situation, sitting in an office with Atlanta with access to, student mental health services, what does that mean for my study staff, for my team that is living in Swaziland, where at the time there was one national psychologist, literally one psychologist for a country of 1 million people that we could give our study team access to, where there are different schemas and discourse about mental health and trauma, and where really there is not as much support and conversation about self-care, whatever that means. And I think there's just kind of the basic, you want to be a good person and think about this for your team, but there's also some pretty specific ethical concerns that we can link back to really the groundwork of what we think of when we think of ethics in public health and medical research, which is it is our job to think about, is there potential harm in what we're doing? And I would argue that it's important that we think not only about harm to research subjects, like Purnima laid out so beautifully, but also is there potential harm to our staff, especially when there are large power differentials between different members of the staff, and when there are large differentials in who has access to what resources. It's also important to think about, we don't want our staff to burn out because we are good people and don't want our staff to burn out. But if you have staff that are burnt out, that are exhausted, that are not able to be empathetic, that's really bad for your data. And so you are potentially doing a less good study. You are potentially asking people questions that have the potential for harm without the payoff of high quality research. And that is, to my mind, unethical. And then we also have this potential for coercion, not necessarily between, again, human subjects and the study staff, but between the PI and the staff, especially in a lot of countries where we have this sort of gig economy for research, and I'll talk about that in Swaziland as a case study in a minute, where you have a fear of losing your current job or a future job, or where there's a real difference in the risks and benefits of the research work, right? So I say I want to do a study on food security among female sex workers in Swaziland. The risk of that to me is kind of low. It's really stressful to write a grant. I might have to ask for an extension, but there's not a real risk to me. And the reward is quite high, right? I get to come here and give a talk to you. It's a pilot data for more grants. There's a high reward. But for my staff, the risk can be quite high, and I'll give some examples of that in a minute. And the benefits are maybe a salary that's equivalent to $50 a day, and that's a good salary. And so that trade-off between risk and benefit, I think, is not quite even, and that's something we need to think about. So what I did, what I wanted to do was really explore this in what's now known as Eswatini, what's formerly known as Swaziland. Swaziland, just a little bit of context, has the highest HIV prevalence in the world. It tops out at about 50% for women in their late 20s and early 30s, and about 45% for men in their late 30s. It's very high. I will also tell you, Swaziland is one of the first countries in the world to basically achieve and now looking at surpass the 90-90-90 goals. Certainly better than the United States. So in Swaziland, in Eswatini, 90% of people know their status. Just about 90% of those are linked to care, and just about 90% of those are virally suppressed. So very high prevalence rates, but also an incredibly proactive and evidence-informed Ministry of Health. So because of that, and because it's just a really beautiful, pleasant place to live, there is a lot of HIV and violence research that happens in Eswatini. I say it's really beautiful. This picture down here is actually just the view from my front porch when I lived there for a year. Like, I just got to look at that and drink coffee every morning. But there's a lot of research. And so what I really wanted to do was understand these experiences of emotional distress and secondary trauma among frontline staff in Eswatini, and think about what personal strategies for resilience they had, and how we could think about potentially mitigating some of these. So it was a simple qualitative study. We did in-depth interviews with in-depth interviewers, with quantitative survey administrators, with transcriptionists. We talked about the same amount of men and women. And we began with pilot interviews, just talking to colleagues, who should we talk to, and just did snowball sampling on from there. And I worked very closely with 2 local study coordinators who were actually my study staff on that initial study of with female sex workers living with HIV, who I am still good friends with and keep in touch with. And so they really coordinated this, did the recruitment in country, and conducted these interviews. So overall, we talked to about 21 people, and they worked on a range of studies from cancer to child abuse to HIV, sexual violence, LGBT health. And in Swaziland, LGBT community is illegal-ish. Sex between men is functionally illegal. The government doesn't really acknowledge that lesbians exist, but if they knew, it would probably be illegal. So it's highly stigmatized and as illegal as it matters as far as the police goes. So when we looked at all of these interviews, we found this really interesting pattern where there was real harm that was happening to people. People were experiencing individual harm. People reported, because of the work, substance misuse, experiencing anxiety and depression, experiencing harm to their relationships, sort of spillover stigma from the type of topics that they worked on. But that was really grounded in this context of, because we were drawing people from the broader community, they had experienced all of the things that they were doing research on. So it wasn't like they were just saying, oh, in the abstract, you have experienced, you lost a parent to HIV. It's very likely that the researchers, the frontline researchers, had also lost a parent to HIV, or a cousin or an aunt. They're reporting on things they'd experienced. And so in this, what people told us were things like, I remember there was this homestead I went to. It belonged to a grandmother who lived with her grandchildren. When I introduced myself to her, she pleaded that I help her by taking her granddaughter. She said the child's parents had both succumbed to AIDS and she can't support the child. She pleaded for me to take her in order to help her ease the burden. And that's just one of many emotionally draining experiences. This is people's daily work, you know? Um, and so in that context, you also have, um, of course, you want to hire people who are empathetic, who can draw out these narratives. And so you are almost purposefully hiring people who are at higher risk, right? And so people said, you know, I'm empathetic, I'm a loving person, I love children, which is why you want this person doing research about children or interviewing children. But then that same empathy puts them at risk. And this person said, you know, I tend to imagine, what if that's my own child? What would I do? Um, we also saw that just sort of the workplace conditions could really exacerbate some of this risk and stress. So if the questionnaires are too long, deadlines always get pushed, studies always run late, and you can and the person at the very end of it is the data collector who's told, okay, we're 3 months late. Can you go out and collect 50 surveys instead of 12? And that's stressful. It's really, really stressful. Um, and then, you know, like I said, through this exacerbation in the workplace, people really reported, you know, experiencing anxiety, depression, substance use. The idea of suicidality actually came up a couple of times. Whether that's hearsay or something that actually happens, I couldn't tell you, but a couple informants did allude to that. And you find that through this spillover stigma, relationships, which were really the primary site of coping, right? People talk about their work as a way to kind of decompress. That was also one of the things that was most likely to be harmed, either through spillover stigma or because people were so stressed out that they just wouldn't want to talk to their friends or partners. They would withdraw. Um, and so when we talked to people about what they wanted, what staff recommended, what they really recommended is building in opportunities for self-care. One person said, you know, I think we should get to go to the spa. And I was like, yeah, okay, me too. And then I thought about it and I was like, yes, actually, you should build in retreats and opportunities, not necessarily for self-care, but for collective care. You can think of it like OSHA requirements, right? If you are asking people to do something dangerous or putting them in a situation with the potential for harm, it is your job as the employer to mitigate that workplace harm and to do what you can to prevent it. And if that looks like collective opportunities for debriefing, for relaxing, for retreats, for access to professional services, then absolutely, that's what you should do. And you know what I really saw coming out of this is that there is not an opportunity for people to grow up. The leadership really stays in the global north with the benefits, and the risk really stays in the global south without an opportunity to climb. And so my my thinking after doing the study and after doing this work for a while is making sure that people have the opportunity to sort of climb that ladder, to build capacity, to make sure that you have real local engagement. You're not parachuting in, which I'm sure is something that gets talked about a lot, and to maybe think about what does a fair trade shop look like for data collection. What does that mean, and what could that look like in the research context? So I know I talked much too long, so I'll stop there, but I'm so happy to take your questions and to just talk.
Thank you. Thank you so much to both of you. Once again, as a reminder, if anyone has questions, please do submit them to me via the chat function. But I'll go ahead and get the discussion started. I was sort of struck by a lot of, so Rebecca, a lot of your discussion in particular, it seems like that also translates, a lot of what you said also translates to similar research in the domestic context, right? And so I was curious to hear your thoughts about, and this goes out to both of you. So do you think that in general, the lessons we draw about ethical research in the international context translates to the domestic context and vice versa? Or are there like really distinctive things, really distinctive differences between these two contexts that make some of these lessons not translatable in the same sort of way?
I think there's really clear parallels. So for example, I was talking with a colleague who does a lot of work in Indian country and Native American communities in the Southwest, and she was sharing there we go. Um, she was sharing that she wanted to take on a project that involved a particular topic that she thought was really important, but one of her staff members had previous experience with that topic and didn't feel that that was something they could comfortably engage in depth. And my colleague was really torn because they felt this public health topic was really important, but they also really deeply valued this staff member and didn't want to lose them, push them aside, do something that would cause them harm. And I think that's pretty common, actually, in particular in the type of work that we do around, we know I do a lot of work on campus sexual assault, right, in Eswatini, but also we know that 1 in 4 students in the US have experienced, female students in the US have experienced sexual violence. And so when I work with students on some of this data, we have a lot of conversations about sort of self-care and what it might feel like to be reading these transcripts of sexual violence, whether in your own context or in another country. And I think being mindful of one another's shared humanity is a universal, no matter where you are or what you're doing.
I agree with Rebecca. I don't think that we can separate out what happens in the global south to be any different than global north. It also depends on what kind of topics you're working on. For example, here in Arizona, Tucson is the closest city for the border population. We do a lot of work in the Mexico-US border. And the communities that we have just inside of the US as compared to the Mexico side, the US side is literally like going back to some of the most rural, remote areas in India for me. They don't have access to healthcare. They're undocumented. There's no way they can go and complain or share their issues with anybody. So what they have to do is they have to cross the border in order to get healthcare. And there are completely separate risks associated just with that. So I think one other thing we have to be mindful of when we are doing any kind of community-based research is the mental health of all of our research team members. And that reflects, it just reflects in how you collect data and what kind of data you're collecting. It all matters in the end.
A question from the audience. So this is for Dr. Fielding Miller. Did your participants talk about whether they felt that they had sufficient training by and support from their supervisors to deal with the dilemmas or the stress that they encountered? So although it does raise questions about how you prepare research teams for those types of dilemmas.
That's a really good question. So I was trying to give sort of a 30,000 foot view to not take up all of your time, but there was a lot of conversations about supervisors, about how you could structure a workplace to really mitigate some of these harms. And there was this interesting dynamic where a lot of folks who sort of take these initial beginning positions will come out of social work or social science, and they'll be so excited about the notion of doing research to improve their country as service, really. And what will often happen is they will feel that either their technical skills are belittled or undervalued in a way that is frustrating. And one spoke about, there's all this money sloshing around, and they pay us nothing. And also that there are these sort of really, in some shops, there can be very stringent hierarchies where people don't feel comfortable talking with their supervisors. And it was very clear that in places where people felt that their supervisor was approachable, they could have these conversations, that was just a better environment, and these harms ended up getting magnified a lot less. One thing we noticed that was really specific, and something I passed along to colleagues who worked in the country, is there seemed to be a pretty broad misinterpretation of what confidentiality meant. So a lot of people seem to interpret participant confidentiality to mean they couldn't speak to anybody about what they'd heard, that they couldn't debrief with their colleagues, that they couldn't talk to their boss, that they just had to keep everything internal forever. And that's obviously not healthy. And so I think there is an opportunity there to build in even just an opportunity for an hour a week for people to talk in some kind of structured situation to release some of the pressure and the pain there.
As a sort of a follow-up to this, and try to bring in Purnima as well on this. So I was also very curious about conflicts and understandings about the values that are driving how to do the research project, how to shape the research, how to engage in it. And especially when you're working with, people on the ground who have different backgrounds, different sets of trainings, I think there's a lot of opportunities for those differences of understanding of these values. But also, I think sometimes the differences can come from the values themselves. So there can be a conflict in the values between different members of the research team, especially if people are coming from different cultural backgrounds. And so I'm wondering, how does a researcher navigate those potential conflicts between the members of the research team? Especially, so just to say a little bit in the background here, I think, there are some concerns about trying to impose your understanding of values in general on the other members of the research team. But it seems like in this research ethics context where you are trained with that this is what these values mean, these are what these procedures are meant to do, it seems less bad to try to impose your understanding on the other members of the research team. So I'm curious if you could speak to that or had any thoughts about that.
Yes, we all come with lived experiences. We come with a different set of values. But when we, as researchers from the global north, are going down to a resource-limited setting, working in a vulnerable community with vulnerable populations, and you have a group of researchers there who are working with you, you already have an inherent power differential because you're going with the money. So you are already, like, even the researchers on the ground are going to treat you differently. They're afraid that, if they say something, you're going to leave. So the first and foremost thing you want to do, even before you take money to go and do research in some place, is to build capacity at that level and to build trust, to make sure that you are both on equal footing. That's why it takes so long to do international research. It's not like you write a grant and you can go down there and do the studies. It takes a long time to actually, it's just like gardening, you have to till the soil, you have to prepare the soil, you have to wait for the right conditions. And it's only when the conditions are right, you sow the seed. That's what I think of as that research is that seed that you're going to sow after you have done all of this prep work, making sure the ethics committees are working, making sure you have trained your colleagues on the ground, making sure you have a community advisory board that is informing what's going on the community level, and whatever you're asking is appropriate. All of these things are going to be important for us to do even before we start to go and do research. And then this whole issue of value system. Well, when just this example of the cervical cancer clinical trial I'm talking about, where they said, oh, well, there's, no screening is the standard of care. So whose standard of care are we defining? Are we defining the US standard of care? Are we defining the Indian standard of care? And even in the Indian standard of care, are we talking about people who have access to this care or people who don't have access to this care? So this whole issue of justice comes back again and again. So if we can kind of keep in mind the basic principles that Rebecca showed in the slide, which was awesome, if we can make sure that we are following all of those things, no matter what your cultural differences are, we can always come to terms with it as long as we're not violating those basic tenets, the ethical principles.
Yeah, I think a lot of it for me is about making sure that you are in genuine relationship with people. So are there going to be cultural differences about what collective care or self-care or like mental health care looks like? Sure, definitely. And part of this project was getting a sense of, what are schemas of mental health, what are strategies of resilience that are useful to folks. And some people said, we want a therapist to come in once a week, and some people said, no, like mental health care is totally taboo and we just want to debrief. And that's fine. But the work, I think, has to be in being in honest relationship with people to the point where you can have genuine conversations so that you can figure out what works for everybody. Because you can, I think it's a little bit of a cheat to just say, oh, well, we have different cultures, so the thing that works for me isn't going to work for you. There's just different concepts of mental health. The end, you don't need a therapist. I think that's cheating. I think it's much better to, like Purnima said, really put in the work, the building, the sort of tilling, the nurturing of the relationship so that you can have an honest conversation and figure out what people genuinely need. And I think you can't do that unless you see people as fundamental equals, even if one of you has access to the grant funding and the other doesn't.
I just wanted to add to what Rebecca said. One of the things she was talking about, how do you care for your researchers? One of the things we have done at our institute in India is when we take on any projects, we do all of the basic training and everything. But when we start doing the recruitment, so like every time we reach a small milestone, we have baby milestones. If we have to recruit 100 people, we have milestones for 10, 50. So we have like little party. Or we'll say, okay, we're going to go and have biryani today because we've reached 25 people. So we start having these small little celebrations. So what that does is it strengthens the teams. Teams start working together and they want to do it together. They want to help each other. So it's not a competition between them, but it's like, let's do this as a group. What that helps is they are supporting each other. They become each other's support system. So building that kind of a system into place, making sure that everybody is valued, from an outreach worker to an interviewer. So making all of them feel like they're all contributing, they're all being part of the study, and we are all celebrating together. It helps. And I will tell you, almost all of our studies we've done in our site have had excellent retention for that reason. And that reason only is because of our team members.
Yeah, I think that's the other argument is you're not just being a good person, like selfishly your data are going to be better. Like you're going to have a better study too.
Yeah.
So you've both really anticipated something else that I was hoping that we were going to be able to talk a bit about. So this last exchange, you talked quite a bit about relationships and trust. And one of our previous discussions in the series was about trust and mistrust or distrust within research. And so I'm curious, how important do you see trust being within your research? And what is the relationship between trust and relationships within the kinds of things that you're doing?
I cannot stress it enough. Right now with the COVID work I'm doing, even just as early March last year when the COVID whole thing was happening, I was already trying to set up what to expect 1 year from now. And we had actually started to do some formative work trying to get people to tell us, would they consider a vaccine if a vaccine became available? And we did like about 11 focus group discussions, stratified by sex, stratified by race, stratified by education. What was really interesting is it's close to impossible to get African-American males and Hispanic males to give you 15 minutes of time to sit down and talk to you. It's hard. So that was one conclusion. I have to find strategies for that. But the themes that kept coming back and again in communities of color for us as to whether they would consider it was trust. They would not trust the system. They do not trust the healthcare providers. They do not trust the researchers. At every level, there was some issue around trust or not trusting. So I think regardless of whether you're doing research or rolling out interventions, if you cannot build that relationship with your community, if you cannot have that long relationship where they will trust you to want to do what what is expected, it's not going to work. Now look at our COVID vaccine situation. They are most needed in our communities of color. But those are the exact same communities that have the least access, or they're less likely to take it because they don't trust you enough. They're like, we want to wait and see. So I think it comes back to the same thing. It is, how do you build your relationships in the community and how do you nurture them? And sometimes it has to go beyond research. It's not in the context of research. Research happens afterwards. You have to first be able to show to your community that you're there in their best interest. And then you can say, hey, by the way, I have this project. Would you consider it? They will be more likely to consider it. So yeah, trust is, that's not going away at all. And we have a long way to go to build that in our communities.
I think that's completely true. And to continue that example of COVID and vaccine work, I have a long relationship with a local refugee advocacy organization in San Diego County. And when I say long relationship, I mean like 5 years ago, I was introduced to the executive director by one of her staff, who said, hey, we're doing a study. Can you help us? And I was super excited. I was like, okay, we're gonna go get IRB and we're gonna do this, we're gonna do this, we're gonna do this. And the executive director was like, I don't know you. Like, hang on. Maybe just give us some tips on the field guide and I'll see you next month. Okay. Which is fair. She had no idea who I was. But over time, because I live here, this is my community, I believe in the organization, I volunteered with the organization, I ended up serving on a board with that same executive director, and we became actual genuine friends over 4 or 5 years, to the point that she called me up about a year ago and said, okay, we're going to do this study again. We do this biennial survey. We would love to have you help us design the survey and give us some technical support, because now I know you, I trust you, and I trust that you have my organization's interests at heart and you're not just in this for data. And so because we pushed that out in November of this year, we were able to add some COVID questions, including some questions about vaccine hesitancy. And one thing that was really striking is we saw a lot of vaccine hesitancy in the refugee community, particularly the African refugee community. And my friend, who is also of East African descent, was also a little wary of vaccines. We had a lot of conversations about these vaccines. But because we had a long-term trusting relationship, we could just talk honestly about it. And she agreed that even though like she got the skepticism, she also did not trust the federal government and what they might want to be injecting into, African Americans and refugees and immigrants, because I think it's important to point out that I don't even know if we should say distrust. I just feel like we should say knowledge of history, right?
Mm-hmm.
Like these rumors about the COVID vaccine is going to wreck my fertility. Like, yeah, we did that. Like, the US government like sterilized women of color, in particular immigrants and refugees. That's not like something that's coming from nothing. That is a wide-eyed assessment of how people have been historically treated, and not 100 years ago, like 6 months ago in ICE detention, right? Like these ideas aren't coming from nowhere. And so we were able to have a conversation about where these ideas were coming from, and would she potentially be interested in putting in a grant to address vaccine hesitancy, even though I get the reasons why you guys are hesitant, but I think this is important. And she trusted me enough to say, okay, I believe you, let's do this. And that took 5 years of relationship building and friendship, not necessarily just like professional trust, but like we're friends. And I think without having that really long background, we would not have been able to do this work or have this access.
So then, as you're thinking about the international work, there's also clearly a very, very long history there of really deeply problematic things going on. How do researchers continue to build those relationships and advance trust when the projects that they're working on might be time-ended, like they might be constrained by time? You're working on this particular grant project. How can you maintain those relationships historically or into the future?
So one of the things what I've done is I've worked and invested a lot of my efforts in training grants where we can actually build capacity on the ground. And then what happens is when suddenly there's a colleague here who says, I want to do research on TB. How can I do it? I need to apply to this R01. I need a collaborator, or I need to generate pilot data. I need a collaborator. So then what we do is we look at the folks we had trained on the ground, and then we talk to them and say, hey, is there a researcher there who is interested in this topic? And then we facilitate those relationships. So it takes a long time because you want to make sure that both ends, everybody is ready to make that connection to get started on a research project. Just like Rebecca said, it cannot happen in a year. It cannot happen in a month. These are things you have to nurture and cultivate. It's all about relationships. It's a simple thing I'll say. It's like arranged marriages in India, right? You just go and see the person and say, okay, now in 6 months' time, we're going to get married. And then we all laugh at it here. Why is that? Because we believe that we need to get to know the person. We got a date. We need to do everything before we can say, yes, this is the person I want to get married to. So I think it's the same thing for relationships. And in research, you have to make sure you understand not just the topic, but also the personality of the researchers. Do you want to get stuck with this person who's so nasty for next 5 years of your life and write a grant and live through that nightmare? Is something you want to think about, because there are a few people I don't want to do that with. And I gently kind of excuse myself out of those relationships. So that is very important because you are not there personally, physically all the time. That means this person you're going to be working with is representing you and your institution. So you have to have a solid amount of trust to know that that person has your back and is going to do the right thing when you're not there. So you have to cultivate those relationships. I know it takes time, but again, the way you want to think about this is, are you in it? As you know, you can sprint, you can go far, but you want to go really far, you want to have those relationships, and you go at a slower pace, but you'll go much farther than that. So it's all about having that balance of, taking the time, nurturing it, building it, and then going after it. You're going to be sustainable for a longer period of time.
My a colleague who I work very closely with, in Eswatini, she's just really wonderful and a joy to work with, and is always right in the long run. I'll suggest something and she'll go, well, that might work, but consider this. And usually I'll think about it and figure out why she's right a week and a half later. And one time I was talking to her and I said, Fortunate, I don't know why I don't just agree with you in the beginning and save myself a lot of time. She said, well, I think it's better that you come to it yourself, that it's genuine. And I was like, well, okay. But she trusts me enough that she knows I'll get there in the end, and I'm working on just realizing that she's right the first time around.
I have another question from the audience. This one goes to Purnima. So you described the 4 criteria for when a placebo is acceptable: when no treatment is available, when the withholding treatment is negligible risk, when there's a rationale for the placebo but no serious harm, and if treatment will be offered to treatment populations. So it seems as if for the middle two, the negligible risk or no serious harm and methodological rationale, the Global North Research Establishment is making the decision regarding what is acceptable levels of harm and what is methodologically necessary. What is the role of the participant community on making these decisions, and what should it be?
I think it's a very important question. Thank you for that question. I don't think we in the Global North should be making those decisions by ourselves, number one. If this is a study that's happening in an international site, in wherever, even if it is here in domestic, if we are going into the reservations and working, unless we have the complete consent and acceptance from the researchers from those communities, and when they are fully informed. Not that you're just taking their yes, no with limited knowledge, but explaining to them all the different options and making sure that they are well informed, and then they say, yes, this makes sense to have a placebo. That's the way to do it. You want to have consensus and an informed decision based on those consensus. For example, in this clinical trial, the fact that they did not even inform the women in the no screening arm that they had options of a pap smear, or that they could go and see a doctor, and they watched for 17 years to see if that woman died, is just not acceptable in any which way you look at it. But that's just me. But that's not what the researchers are saying. The researchers are saying they're justified in doing this. So there's always, two sides to a story, and they're not here to justify, but I'm saying this is not acceptable to me, according to my ethics.
So now here's an audience question for Rebecca. So how do you think the vicarious distress that you have described is related to moral distress, which has been described as the research workers' distress that their role is preventing them from doing what is right for the participant population?
Yeah, that's a really good question. So one thing that came up pretty frequently, especially when people were talking about workload, was the folks who were doing the data collection in the field were the ones who were really seeing how people were responding to the surveys. And we're seeing that this survey is too long. People are making up answers to get through this. This is stressful, like it's done, this question doesn't make sense. And there was some frustration there because people were going out every day, they were working really long hours, they were kind of engaging in these some upsetting data collection, and then they were seeing that by the end of these surveys people were just making stuff up to get it over with. And I think that really exacerbated some of the distress that people were feeling, is on top of all of these experiences of these really kind of emotionally wrought experiences, they were also seeing that the data weren't coming out right. And so I know that I have made it a personal practice to always make sure that I'm having good long conversations with people who are doing the direct data collection, because I feel like they see so much more than ever makes it into a database, right? Even in qualitative research, the conversations that people have before and after, the stuff they notice is so incredibly valuable. And I think it also alleviates some of that burden of feeling like this is just going to be garbage in and garbage out, and we're all experiencing this for nothing. So yeah, they definitely intertwine quite a bit.
As a reminder, if there's any other audience members who would like to ask questions, please do send them in the chat. So I guess I'd like to hear a little bit more about so Rebecca, you had mentioned that your work is driven by this concern about intersectionality, and especially thinking about the entire research team and how their different positionality, how their different resources makes different members more susceptible to risks, and differential in terms of the benefits that they receive from engaging in the research activity or participating in the research, et cetera. So I'm curious to hear from both of you, like, what are the sorts of responsibilities that the researchers that are coming in from the global north have to build the so Purnima, you talked about, you do a lot of training grants and capacity building grants, things like that. So what sort of responsibilities do the Global North researchers have to engage with the researchers in the way that will maximize the benefits to the researchers on the ground or the other participants on the ground?
I think there's certainly an obligation to, make sure that you are building in as much capacity building as possible. So when I do a lot of work with the University of Eswatini, and so I will do scientific writing workshops, because that's often a very gatekeepy part of the field, where even if you have all the expertise in the world, you have to structure things and phrase things in a very specific way that people might not have training in. And so making sure that people have access to some training in scientific writing, here's what a journal editor is looking for, that type of thing is really important, and something I try to make accessible. Checking in with my staff and kind of having a sense of where they want to go next, and doing what I can to help them build up their CV in whatever direction. It's hard because in a lot of places, certainly where I work, there is a very much a gig economy of research when it comes to the data collection side of things. There are not sort of bigger institutions. People will kind of, pop by the local university and hire a recent graduate to go and do some interviews, and maybe you see them again and maybe you don't. And it's really hard, especially as early career faculty, to just like set up a data collection consulting firm to do all your stuff and just have everybody hired full time for 20 years with full pay and pension. You can't build that overnight. But I do at the very least try to be mindful of where do people see themselves going? How can I support that? Is authorship a worthwhile currency? And if so, let's work together and make sure that you get your name on that. When we did actually this study, the two study coordinators, Nongchangsha and Snelly Siwe, actually came out to the big conference in Cape Town where we presented our findings, and they were the ones who presented it. They had all the networking and sort of professional development opportunities that came with that. We made sure they stayed in a really nice place because they'd never been to Cape Town before. And that was really important to me, even if they weren't going to go on in a career in research. Snelly Siwe actually is a prison guard, and Nongchangsha is a teacher, but they're both fabulous researchers too. That they had the opportunity to fully participate as researchers who were fully vital to the study and deserving of that respect too.
I want to talk a little bit more at a 3,000 feet level now. One of the things that we have been doing is when COVID started, I got a group of my students and I to look at the top 5 journals that had published on COVID. And what we did was we wanted to see where were these papers coming from? Who was the first author? Who was the last author? If it was from Global South, were Global South authors included on those papers? And where were they included? Again, along the lines of justice and equity. You won't believe what we found of the 3,500 articles that we looked at. Only 3.37% of the articles had a first author from a low and middle income country. And even worse was only 1.3% of those papers had a last author from an LMIC. So these are easily addressable issues of making sure that you have authors, if you are doing studies in the Global South, to include them in your papers. And if you from Global North are taking a primary position, to give them the senior position, or vice versa. Not very difficult, but doesn't get done. So there are all these low-hanging fruit that we can start thinking about. Now I consciously don't take a last author position. If I'm working in an LMIC setting, I always give it to my colleagues. So there are ways we can do these things. But I think, again, it's an issue of equity. We have to treat our partners on the ground like you want them to treat you. So if we can help them with their careers, build capacity, build efficacy for them, self-agency, it's going to be a win-win situation for everybody. But a lot of universities here have so much pressure that many times researchers, they start with the right intentions, but then they lose way along the way that they're going. And I think there should be enough guideposts to get them to stop and think every once in a while. Is this worthwhile? And okay, I'm going to get this first author paper now, but at what cost? So I think these are things that need systemic changes as well. So it's not everything that a researcher can do, but sometimes the university has to do some things as well.
Yeah, and I think, I've found that working with my colleagues at the university in Eswatini, sometimes we have different expectations and payoffs, and often it's actually pretty easy to negotiate and make sure that everybody's getting what works best for them. So, and I check, we have those conversations. What looks good for you for advancement? What do you need? So at the University of Eswatini, like any conference presentation, your name anywhere on a manuscript, that is fabulous. But what we don't have are, projectors to teach our classes. And so we write not an MOU, because our university has a lot of lawyers and I don't want to deal with that, but a letter of agreement where we talk about here's whose name is going to be on the papers. Here's what it looks like to submit an abstract. Here is, this doctoral student, we're going to make sure that she has the software, not only the software, but access to a training opportunity in South Africa where she can build her expertise in that software. And here's where the equipment is going at the end of the study to make sure that there is some long-term benefit. We did an intervention in Eswatini that did actually need a projector, and we made sure that was built into the budget so that now they can project slides to teach in class, for goodness sakes. And so it was relatively easy for me to say, I need first author or last author. I'm in my 4th year as an assistant professor. They're both good for me. For you, second author or first author is good. This is great. Let's just talk about it and see which thing works for which person.
So we have a follow-up question from the audience. Purnima, to what extent do you think women's marginalized role in Indian society, at least in lower classes, influenced the perceived acceptability of the cervical cancer study?
That was a huge one. I think the fact that these trials were done in the most disadvantaged communities, with the most uneducated, poor communities, just for that sake alone, the researchers should have been extra careful in what they were sharing and how they were explaining that informed consent form. I mean, when you're talking about consent, especially in, I can't speak for all countries, but at least in India, there is this whole issue of how do you even get the consent? Because nobody signs a consent form, even for a surgical procedure in India, right? The doctors just come and they say, you're going to have a hysterectomy. And the woman would say, oh, speak to my husband. And the husband is going to decide whether this woman is going to get hysterectomy or not. That's the cultural setup. So knowing that, how are you recruiting this woman from the most uneducated, most disparate community and explaining to her that she's going to be part of a clinical trial where she's going to be randomized to one of the 2 arms, and one of that arm may not have the intervention? And how are you explaining what her options are? All of these things will matter. And it has to be done in a language and at a level that she can understand. So where was the ethics committee in this? What were the researchers, the Indian side researchers, thinking when they were, going out into the communities and addressing these issues? So it matters a lot. But I don't think we can say that, it's the woman's responsibility. It is the researcher's responsibility to make sure that the person who's participating in your study is completely informed of all their options, of even when they can leave your study. And I don't think that was done correctly. And that is what I'm saying. It is very important that we have eyes and ears at every level when you're especially working in vulnerable communities in these kind of settings. So yes, what you said in terms of the woman, her position in the hierarchy in the Indian system definitely has a huge influence on how she's even going to interpret or understand what you're telling her. If a doctor from a Tata Memorial Cancer Center is going to go down and say, oh, we're going to give you $50 for you to come and just be part of a study, when a woman makes $2 a day, would she consider it or would she not consider it? So maybe $50 is not coercion in the US, but for a woman who makes $2 a day, would you consider that coercion? And how are you explaining to her about the randomization? What options are you giving her? All of it matters.
To Rebecca, a question. So in Swaziland, would a study on trauma be as acceptable if participants were male, especially given the marginalized nature of men who have sex with men?
Yeah, so one thing that was actually really interesting about this study is more of our participants with the research staff, the frontline staff, were actually men. 13 of our informants were men and 8 were women. So these narratives are coming from male staff just as much as female staff. I think, and this is based on my relationship with and knowledge of the LGBT community in Eswatini, where I have colleagues who I have known for a decade. I think if done carefully and executed in partnership with a known organization, that would actually be really welcomed. I think that if it is seen as something that is coming from the community and as an act of care and visibility for the community, yeah, I think that would be something that's really something that folks would get excited about, because it's a known problem. And actually, we are working on right now. So one of the projects that I've been working on that I alluded to is campus sexual assaults in Eswatini. So we did the first study looking at the prevalence of campus sexual violence on the African continent, I think in the global south, actually. I've never seen another one. And we found very, very high rates of sexual violence, but we also found very high rates of depression, anxiety, PTSD. And that was something that caught my colleague Fortunate's eye immediately, because she has seen, as somebody on this campus working with these students, she has seen that it's a problem. Anecdotally, there are very high rates of suicidality, of self-harm, of depression. I mean, when you think about the level of the HIV prevalence in country, there's an enormous amount of trauma, undealt with trauma in that country. And in our country right now, but also there. And so we actually are having a lot of conversations about how do we assess mental health? How do we study trauma? What does a potential intervention look like that's culturally acceptable? And in fact, she just sent me last week a protocol that they're looking on to assess the prevalence of suicidality in their students. And she sent it to me and said, would you work on this with us? We're all doing it for free. There's no money, but we think it's really important. And I said, of course, sign me up. I agree, this is really important. So yeah, I think it'd be very welcome. And in fact, it is, and it's something we're working on.
We are all operating within, the context of this global pandemic, and I know that there's a lot of people who are curious. How has the situation affected this kind of work that you've been doing internationally? What have been the impacts of that kind of work? And maybe even if you could speak to your understanding of the impacts of the COVID crisis on public health research more generally.
I can tell you, it's really hard to do focus groups virtually. It's close to impossible. The focus groups that we try to do virtually, where you have everybody like this is Hollywood Squares and everybody is there and you're setting out a question. Yeah, they're going to answer your question, but you don't have that organic interactions that you would see if you were just sitting in person. And there's so many challenges when somebody doesn't turn on their video. This whole idea of capturing the nonverbals, it's a struggle. So I think just the whole idea of how do you even implement the research has taken on a whole new meaning. How do you go about carrying out your data collection? How do you even reach out to your participants has taken a whole new meaning. So for us, a lot of our studies have come to a standstill, and it's fair that we don't put our team members at risk either to go out into the community. So even in an international setting, we had stopped all of our work. But I have to tell you, those guys have recovered much faster than we have recovered in the United States. I mean, our response to COVID is the worst, is all I can say. Because back in India, they're back to work, they're out in the communities already, and data collection has started. So they're all back to normal. And we are the ones who are struggling at this end, still trying to figure out, are you going out? How are you reaching out to your participants? And when are you going to do it? When are you going to get vaccinated? When is your community going to get vaccinated so that you can go and start talking to them? And this whole concept of research is the last thing on your community partners' minds right now, because they're trying to roll out the COVID resources. So nobody wants to talk to you. There are all these calls for proposals, and these are your dearest friends who you've been working with. But they're like, we don't even have the bandwidth to engage with you right now because we've got all of this stuff to take care of. So I think the research in itself is going to be put behind for almost a year or two for a lot of people. And as a female researchers who have, I mean, I don't know how Rebecca is doing it with a 3-year-old. I think female academics and female researchers have taken a huge toll in this COVID situation in terms of research and productivity. Not that they don't want to do it, it's just not possible. And again, the institutions, university, the leadership needs to do something about it. And they cannot hold us all to the same a level of productivity pre-COVID.
Yeah. Oh boy. Yeah. I think everything you just said. Yeah. So I definitely went about 2-3 months in the middle of this with no childcare because the school shut down, my daycare shut down. Everybody was scrambling to figure out if daycare was allowed to be open. It took us a minute to realize because I'm an epidemiologist, I definitely count as an essential worker in a pandemic. So we managed to find childcare again. And yeah, and I have a progress report due on. I have a KO1, and I just want to send him a picture like nobody in my family got COVID. Like there, what do you want? Like there's my progress report. And I think it's been really challenging for global work. So I have a project in Tanzania. We were literally, I think right about this time last year, I was on a call with some colleagues in Tanzania. We were about to start some focus groups to understand some really interesting quantitative findings that definitely needed to be contextualized with some qualitative work. And they said, oh, well, we'll get back to you next week because like this COVID thing seems to be happening and we need to figure out safety protocols. Obviously, that never happened. And it's actually a bit of an issue in Tanzania. The Tanzanian government in particular is reporting they have had no cases of COVID since April, and they are declining all COVID-19 vaccine shipments because they're a conspiracy from the global north. So I will probably not be continuing my work in Tanzania because I don't think it would be safe for me, for my participants, or for study staff, certainly. In the meantime, Swaziland is beginning to roll out COVID vaccines this month. And so we had put in an NIH grant last January, got a reasonable score, and in another world would have resubmitted last May, but obviously did not. And so I was just texting with my colleague and said, you know, if we put this in May and anticipate, you know, I don't know, a February start date, do we feel like that's good timing, things will be under control? And she was like, yeah, let's do it. But it was, you know, a study with some momentum that we just like slammed on the brakes for a year. And data collection in a pandemic is hard. That said, it's been really, I think, an interesting illustration. I've been teaching global health this term, and obviously COVID has come up a lot. And it was on the first day, we talked about COVID and we talked about what a successful response looks like. And, you know, we looked at statistics from South Africa, from Ghana, from India, and from the US. And we talked about, why do we assume that these countries would have worse numbers when it really looks like they've done a really great job with their public health response, and we have not? So what does it mean that we are assuming that we deserve a place of public health leadership? I don't know. It's been a wild year. I can't wait to leave my house again.
And so we're pretty much out of time, but I would just want to give you the opportunity to answer one final wrap-up question, which is, so we've got some young researchers in the room. What is one thing, one piece of advice or thought that you would like to leave them with?
Well, for all you budding researchers who want to do research in a global health setting, the one thing I'll tell you, no matter how educated, how trained you are, leave all the expectations behind and be humble enough. Have that humility to go and say, when you go out there, you're going to learn something. And that learning can come in many different ways, at a professional level, at a personal level, but it is going to be a different ride, and it's going to be a wild ride. So be prepared for it. Be prepared for failure. And there's nothing wrong with failure. Just learn from those failures, use those as opportunities. That's what I've done. I've failed more times than I have actually succeeded. Nobody tells you about it, but trust me, we've all failed miserably at multiple times, and use those opportunities to actually learn from them. So having that humility is what is going to take you a long way from now. And I wish you all the best. You're free to contact me anytime, and I will do my best to connect you to my networks if you need any. Thank you.
I think the fundamental centering idea that really works for me is, public health, I think at its best, and global health should not be coming from a place of charity. It should be coming from a place of solidarity, right? We are doing this together. And I used this quote in slides so often that I finally gave up and had to pay money for it, and it sits behind me in my office. And it's from Lila Watson, who's an Aboriginal organizer, and it says, if you've, wait, I'm gonna have to turn around and read it. It says, if you've come to help me, you're wasting your time. But if you've come to work with me because your liberation is bound up with mine, then let's work together. And that really, I think, is at the center of a lot of what I try to do. And sometimes I fail and don't do that, but I keep trying to come back to it.
I think that's a lovely note to end on. So thank you both for the really fabulous conversation, and a round of virtual applause to our panelists. Thank you so much.
Thanks, everyone.